Hi, everyone. Tonight we have another subspecialty VMR, this time with oncology subspecialty VMR, with two incredible educators, Laura and Sam. First, I asked them if it was like okay to ask them, call them by their first name. They said it was, just to make that clear. Also, I would love if they could introduce themselves and talk a little bit about a current project that they have and why they feel like it's important for them. So why don't you go first, Laura, please?
Unmute myself. My name is Laura Huppert. I'm a third-year Hem/Onc fellow at UCSF, and I'm really delighted to be here today. So thank you guys all for coming. A current project that I'm excited about, I'm doing a qualitative medical education research project, trying to understand subspecialty career choice. So why do some residents decide to be specialists? And are there different factors in terms of race, ethnicity, gender, identity, et cetera, that influence the choice to become a subspecialist? So working on that with a couple of colleagues, which has been really interesting.
Sounds a fascinating project. Please go next, Sam.
Hi, everybody, and hi to those who I met last time. I'm Sam Brondfield. I'm in my third year on faculty at UCSF in hematology oncology and do some hospital medicine attending as well. A project I'm working on right now, one that I'm passionate about, is in the area of transgender and non-binary people. And the first project in the series that we're doing, that we're writing up now, is it's about how best to document gender and sex characteristics in clinical notes to best kind of affirm a patient's identity in those areas. Right now, a lot of people across the country, across the world, don't do a terrific job of doing that. So we're excited to hopefully help improve things in that area.
Sounds amazing. And thank you for doing this project. I think it's really, really important. So we have here Andrea and Shema, both will helping us with this session. So Andrea, could you please introduce yourself?
Hi, I am a medical student from Peru and a research assistant at Roswell Park in Buffalo, New York. And I have special love for Hem/Onc too.
Please go next, Shema.
It's my turn, okay. Hi, I'm Shema, and I'm a fifth-year medical student from Germany, and very thrilled to be here. Who's the next? I don't know.
No, we can already start.
Oh, okay.
No problem. So Andrea, are you doing the scribing or the teaching points?
I am doing teaching points.
Shema, are you scribing?
Yes,
Okay.
I would do it.
Okay, thank you. So whenever you're ready, we can start. So last time we always asked Laura first. This time we'll switch roles and ask Sam first. He wants to be challenged, be the first to analyze the piece of information. As we wait for Shema, Dr. Sam, I actually have a personal question that I'm really interested in asking you. So you went to do like a medical education master, right? And what motivated you to do so? I think it's important for other people like me that wants to be a medical educator in the future, how that impacted you, the way that you teach now.
Yeah. Yeah, the degree I got, it's a Master of Arts in Education degree, which is technically a research degree. So it gave me a lot of learning about research methods and how to do and conduct research projects within education. So it was really helpful for my research career. It also was a great foot in the door to have an additional degree. More and more people interested in medical education are getting additional degrees now, in addition to their MD. And it can be helpful when you're applying to positions like directors of programs and that kind of stuff. You can definitely still be an educator without any other degree. Laura is an amazing educator and does not have an education master's and is on this incredible trajectory toward immense success. So you definitely don't need it, but it has been helpful for me.
Okay, thank you. Sounds awesome. Shema, maybe we can start. Please let me know if you need me to repeat any piece of information. So this is a 75-year-old female. Actually, a 75-year-old female with past medical history of hypertension, coronary artery disease, iron deficiency, and was found to have elevated LFTs. Just a little bit of background. This patient also endorses diarrhea, 2-3 stools a day. She also endorses extreme fatigue, lower extremity swelling that has been increased, despite the fact that this patient has limited appetite and has been eating and drinking less than normal. This patient refers proximal weakness over the past few weeks. She's largely confined to bed and used to be independent in all ADLs. This patient also has a 2-3-year history of iron deficiency anemia, some nausea, but no significant abdominal pain. To finish this aliquot, one more piece of information. She underwent EGD and colonoscopy without significant findings other than H. pylori, and completed treatment. And a small bowel biopsy was negative for H. pylori. And that's the end of the aliquot. So Sam, how would you approach this? What goes into your mind when you see such piece of information?
Yeah, definitely a lot of interesting stuff here, and could be due to common things, unusual things. So it's a relatively elderly person who has a cardiovascular history that's fairly standard for someone her age. It sounds like we don't know the extent of the CAD or the extent of the hypertension from what we're given. The iron deficiency anemia is interesting as one of the first things that was presented, and it sounds like has had some workup for that, an EGD and colonoscopy that just showed H. pylori. So I'm already thinking, what is the cause of that? Was this a chronic gastritis with slow blood loss from the H. pylori that's now going to resolve after it's treated? I don't think of H. pylori as a major cause of severe anemia. We don't know how severe the anemia is. I'm definitely worried there's another cause that we haven't found yet. And for that, I definitely think of GI and GYN losses. Haven't heard anything about the presence or absence of vaginal bleeding, but another source that would definitely be concerning in an older woman. So already keyed into that, and I'm curious about the severity of the iron deficiency and any other workup that may have been sent for it. The LFTs being abnormal, definitely will want to know which LFTs. Is it a transaminase elevation? Is it a hyperbilirubinemia? Is it an alk phos elevation or some combination? Because the causes of each of those are quite different. The fatigue, I'm just kind of going symptom by symptom. Fatigue has a long differential and is also very common in older people for a variety of reasons, some of which are more concerning than others. Anemia is absolutely a cause of fatigue. Who knows if those are connected or if there's a different cause at this point. The lower extremity swelling also common in older people, common cause being just incompetent veins. But in the context of elevated LFTs, I worry about depending on the pattern, could this be a more aggressive liver dysfunction bordering on liver failure, causing hypoalbuminemia? Is there portal hypertension involved? Is there cirrhosis involved? What's the kidney function like? What's the heart function like? Just thinking of other causes of lower extremity swelling and knowing she has cardiac disease. Appetite, again, that could be in conjunction with fatigue, just not feeling well, or is there a focal lesion in the abdomen or the GI tract that's contributing to the GI bleeding and loss of appetite. I always think of getting full early as another sign. Could there be splenomegaly here or some other lesion limiting the size of the stomach? The weakness, the proximal weakness, could this be actually diffuse weakness in conjunction with the fatigue and the anemia, or is this true proximal muscle weakness and thinking about muscular, neuromuscular, neurologic causes of weakness? Always thinking about paraneoplastic stuff. But there's a very broad differential for pretty much all these things right now. In terms of next steps, definitely interested in the exam, more history, basic labs, the pattern of the LFTs, the severity of the anemia, the other cell counts to know if this is just an anemia or more of a pancytopenia picture. And from the GI standpoint, I know I'm going on a lot, but the GI standpoint, EGD colo is great and a good first pass. It doesn't catch the small bowel. So could there be like a small bowel lesion leading to blood loss here? Again, the GYN workup also will be important. And yeah, I think that's where I would start with this. I'm curious to see what more workup shows at this point, and imaging may become important too, depending on the workup that's done. Certainly some liver imaging, at least starting with an ultrasound to see what's going on with these LFTs.
Oh, incredible, Sam. Laura, for you, I think could I ask you, when you have like 75-year-old female presenting with chronic anemia, what are the things that go through your mind? If you could think because it's such a very common diagnosis.
Very common, yeah.
Yeah.
So I generally think of, when I think of anemia, I think of blood loss, or you think of hemolysis type picture. And so checking labs to differentiate that. And then blood loss, I think common things being common, GI blood loss being the most common chronically. The other place you can bleed into is your retroperitoneal bleed, although it would less likely be in this situation, but like procedural bleed that's big, that's another place where you could bleed a lot. You could ask about blood in the urine, although usually you're less likely to really drop your hemoglobin hematocrit with a urinary bleed. It's more likely a GI bleed. The other thing I think about in terms of malignancy too is your bone marrow is what makes blood. And so if you have diffuse bony involvement, you can actually have so much cancer or whatever process going on in your marrow, non-cancer, whatever malignant or non-malignant process in the bone marrow, they are not producing enough blood cells. And so that could be another cause of anemia. So that's loss or not enough production. And then destruction of blood cells, you're thinking about warm and cold autoimmune hemolytic anemias or other hemolytic processes that could be going on. So I like to check labs to kind of differentiate those buckets and go from there.
Amazing. And from that piece of information that we just got, does anything else stand out for you in this history?
I mean, Sam pretty much covered all of the major things. I guess a few small points. I think once we have the LFTs, the degree of LFT elevation can be helpful and at least giving us some clues. There are very few things that can get the LFTs into the 1,000 range. So having a sense of what degree will give us some clues. And then I always think with proximal muscle weakness, as Sam pointed out, is it diffuse weakness or is it actually focal? Proximal muscle weakness is a buzzword for me. Dermatomyositis, you often see proximal muscle weakness. So, and dermatomyositis can be malignancy associated, seeing as we're in Hem/Onc report. And so it just makes me wonder if she does have a malignant process, could there be a secondary dermatomyositis or other process going on?
Yeah, this is an association that is classic for the boards. Thank you. Anything else to add, or should we go to the next article? Okay, awesome. Shema. Chemistry is most notable for an elevated bilirubin of 11 and direct 8.5, and her AST, ALT are 1,150, and ALT 392. OCT is also elevated at 1,292. Albumin 2.5. Lipase is 105. This patient has a creatinine of 2.7, baseline was 0.9, and CBC showed mild leukocytosis of 12.1. So I guess a concept question here can be made, like, how would you try to explain elevated LFTs, these liver panel tests associated with malignancies? Is there anything that comes to your mind, Sam?
Yeah, definitely. And just to make sure I'm not skipping anything, do we want to do the physical exam and the rest of the history, or you just want to comment on the LFT?
No. We're going to go to the physical exam.
Okay.
This is like a question that I was thinking, how oncologists go over
totally. No problem.
elevated LFTs?
Happy to comment on the LFTs and association with malignancy. So the pattern of LFT elevation is super important. In this case, the bilirubin is really prominently high. The AST is very high compared to the ALT, which is interesting, and the alk phos is quite elevated. So I think there's a couple just mechanistic ways to explain this pattern. I'm also noticing the creatinine, and we don't know yet the association there, but renal dysfunction is common in the setting of severe liver dysfunction and can be due to a couple different mechanisms, including hepatorenal syndrome, which is a vascular explanation, bile cast nephropathy when the bilirubin is super high and bile just kind of crystallizes in the kidneys. So a couple mechanisms there. But for the liver itself, when I see a bili that high with a direct that high, I really worry about obstruction as one possible primary cause that can lead to secondary inflammation and transaminase elevation. So I'd be definitely wanting some imaging of the bile tract to see if there's an obstructive lesion there. On the other hand, the bilirubin can start to go up if there's a really bad insult to the hepatocytes that was primary. So at this point with this pattern, it's hard to say without imaging and further workup, is there a primary obstructive lesion, or was this an insult to the liver? Like Laura mentioned, the transaminases in thousands are concerning for certain etiologies like viral, et cetera, though I'm noticing only the AST is in the thousands, the ALT is significantly lower. And there's other sources of AST other than the liver itself, which makes me wonder, could there be an AST source from muscle, for example, noticing the muscle weakness reported in the case? Could there be rhabdomyolysis going on, and could that explain some of the organ dysfunction like the kidneys that we're seeing? So far I haven't mentioned malignancy at all, but those are just kind of general thoughts about the liver dysfunction that we're seeing here. And we'll definitely need some imaging to further identify what's happening. From the malignancy standpoint, cholangiocarcinoma is an obstructive bile cancer and can certainly lead to a bilirubin elevation. That cancer alone is unlikely to lead to very acute liver dysfunction. That we don't have other prior LFTs to know how acute this is, though I'm worried it's acute based on the story that I'm hearing, but who knows? But cholangio could be at the root of this. Hepatocellular carcinoma can cause transaminase elevations and can certainly cause liver failure in someone, especially with underlying cirrhosis. So that's a possible association. Liver metastases, especially from GI cancers, are common. Knowing the possibility of a GI bleed from the blood loss anemia, though we haven't proven that source yet. Could there be liver metastases that explain these liver abnormalities? The bili of 11 with a direct of 8.5, I'm really worried about lesions blocking the bile ducts, either in the liver or outside of the liver. Pancreatic cancer can cause obstruction in the pancreatic head that can lead to severe liver abnormalities. So those are just my initial thoughts. There are lots of cancers can metastasize to the liver, lots of solid tumors, and there are cancers that can cause people to be super sick really fast, like acute leukemia that can lead to multi-organ dysfunction, leading to liver dysfunction as well. Lymphoma can pop up in the liver. So lots of different possibilities here. And I'm seeing ampullary cancer in the chat. I love that possibility for this case, bringing together the idea of a small bowel lesion that could bleed and also could obstruct the bile ducts. So I'm curious about the small bowel, though an EGD should be able to reach the ampulla and visualize it. And the fact that that was done and didn't see this, who knows? We only heard about H. pylori. Not sure that the EGD went to the duodenum, but most EGDs should. So I'm not sure about an ampullary cancer in this case, but good thought there.
Oh, thank you, Sam. So Lara, AMK is here, and she just answered the question that the LFTs were normal the month prior. So does it change your differentiation somehow, like in a month, such elevated LFTs or not? How would you think about that?
Yeah, I mean, I definitely knowing the time course is helpful in the sense that this is more an acute or maybe subacute. A month is you know, a decent amount of time ago, but more likely an acute process that's going on. And I think Sam laid out a really nice differential in how to think about that. The one other thing I would add malignancy wise is vascular causes like Budd-Chiari. You're more hypercoagulable with cancer. And so when you do get imaging, it's worth seeing if you could get ultrasound with Doppler. That's one thing I feel like sometimes if you forget to get the Doppler, you could miss a clot that could be causing something like this. And Budd-Chiari is certainly something that can get LFTs up into the 1,000 range. So thinking about an obstructive lesion, diffuse involvement of the liver, or a clot could all, you know, in terms of malignancy related reasons. And then of course, non-malignancy related things you'd obviously want to ask about their acetaminophen or Tylenol ingestion, thinking about viral causes. So absolutely asking about, you know, herbs and supplements, thinking about the common things being common as well, and checking viral studies in particular.
Yeah, it's always important to have like a global perspective of the patients. So Anne-Marie is here, and she's the one that prepared this case. So maybe Anne-Marie, if you could introduce yourself and continue the case presentation, please.
Hi everyone, my name is Anne-Marie Cooper. I'm a hospitalist. I actually just finished my shift, so sorry if I am a little bit frazzled, but excited to be here. So I will take over and I'm sorry if I'm repeating things. I missed the first part of the presentation. But as far as past medical history, it was just hypertension, coronary artery disease with a distant history of NMI, and then the iron deficiency anemia we talked about. The medications were aspirin, metoprolol, atorvastatin, vitamin B12, and a multivitamin, no herbal supplements, and had completed H. pylori treatment. And then no like significant Tylenol use or other OTC use. And then social, no tobacco use, never smoker, a social alcohol use, but no significant alcohol use, no other substance use noted. And then lives with spouse, and then no recent travel or recent unusual exposures. Up to date on cancer screening, is like mammogram, and then pap smears, all the age appropriate cancer screening was done. And then family history, there was no family history of GI disorders. There was the mom who had breast cancer diagnosed at age 65. And then as far as the exam, afebrile, and then a normal heart rate and respiratory rate, and blood pressure was in the 140s over 80s, and then saturating 100% on ambient air. As far as general appearance, elderly female, no acute distress, but did look slightly cachectic. The skin was jaundiced and had scattered AKs, mostly throughout the back, a little bit on the chest. When asked, denied this being a new phenomenon. And then there was conjunctival icterus, but no injection. And then the mouth was clear, but with dry mucous membranes. The lungs were clear to auscultation, as the heart was regular rate with no murmurs. The abdomen was soft, non-tender, no organomegaly, felt negative Murphy sign. The extremities had 3+ lower extremity edema on the left and 2+ on the right. Did note some chronic edema, but normally the right was worse than the left. And then on MSK, there was proximal muscle weakness. In the lower extremities, it was 3 out of 5. distally, it was about 4 to 5, and then there was normal strength in the feet, and then the proximal arms were 4 to 5, and then distal was 5 out of 5. Normal deep tendon reflexes. Sorry to all the neurologists in here that I disappointed with that exam. And then kind of some further information. Starts out with a liver ultrasound that demonstrated some moderate intrahepatic biliary dilation. Doppler did not show signs of a portal vein thrombosis or any other clot. And then just kind of some other labs that were seen. The urinalysis showed a spec grab of 1.012, 100 micrograms per deciliter of protein, large blood, 1 RBC, 2 WBCs. And then the TTE showed a normal EF with a trace kind of right-sided pericardial effusion, but with no tamponade physiology, and it was not circumferential. And then CK was checked, and it was 15,000. A urine protein creatinine ratio was 3.79 with a urine albumin to creatinine ratio of 200. And I will stop there and let y'all discuss and kind of tell me what further workup you'd want from here.
Please go next, Sam.
Sure. Yeah, very interesting findings. Not super unexpected in terms of what we talked about so far. I think with the proximal muscle weakness and creatinine elevation, we were all worried that the CK was going to be elevated, and it's seeming like there is muscle breakdown, and that could be at the root of at least some of the renal injury and probably some of the proteinuria and hematuria that we're seeing. The ultrasound showing intrahepatic biliary dilatation doesn't yet totally explain the etiology of the liver dysfunction that we're seeing. And I'll be curious to see if further imaging of the biliary tract may elucidate more of an etiology of this. Starting with a CT abdomen could be helpful. The creatinines may be limiting for contrast. An MRI of the abdomen and maybe even an MRCP could be a nice way to image the liver and the whole abdomen to see what else is going on. So I think we'll probably need more abdominal imaging. So far, kind of trying to put this together, we don't yet have an underlying disease state that we've identified to explain everything. It sounds concerning for an obstructive process, which certainly could be a malignancy. We haven't explained why the muscle breakdown is happening. That could be an acute insult from an infection. It could be a perineoplastic phenomenon. I think we mentioned dermatomyositis earlier. Not hearing about any rashes on the skin, just AKs, but certainly a myositis could be at play here as a perineoplastic phenomenon. I'd be curious if there's other rashes that we're seeing. And the trace pericardial effusion, I think it's a little hard to know how concerning that is. We've got severe liver dysfunction, some kidney dysfunction, some protein loss. Who knows if that's just a minor transudative pericardial effusion, not making too much of that yet compared to the liver, which seems to be the focus. So I'd be focusing primarily on the liver for workup, looking for some kind of lesion or insult there. And glad we got the Doppler ultrasound to rule out portal vein thrombosis and presumably Budd-Chiari as well. Curious what Laura thinks.
No, I very much agree. I mean, I think the question is, yeah, what is the driving process at this point? And I think the intrahepatic biliary dilatation is the one clue. If there's something maybe there that's leading to these LFTs, and what is it? And so getting more abdominal imaging, I totally agree, makes sense. And then connecting that, the liver injury and the Bill-Dil with, you know, the AKI and the elevated CK, like what is the connecting process there, I think is also, you know, you're either a splitter or a lumper in medicine. And sometimes when we're really not sure what's going on, I like to split them all and think of a differential for each one of those things, and then end up at, you know, ideally a unifying diagnosis is more common, but sometimes people will have two totally separate processes. but I'm guessing in her case, it will be one thing. But I think when you don't know what's going on, just from a clinical reasoning standpoint, I like to split to start, and then hopefully we'll end up uniting them. So that would be my approach. So working that up as a separate process at this point as well.
So as a medical student, I've always had this question. When do you, as a hemonc, are interested in more in an ultrasound or in a CT scan when it comes to malignancy workup?
Yeah, it totally depends. Often in the acute setting like this, I mean, an ultrasound makes sense as a first pass workup for the liver because you can get it with Doppler, it's quick. But if that doesn't show you what you need, we'll often go towards a CT or an MRI, abdomen, pelvis, depending on the situation. There are certain scenarios where there's even special CTs, like for example, for pancreatic cancer, you can protocol it so it's more specifically looking at the pancreas. So sometimes even if you just order a normal CT, it won't specifically look at that as well. And so these are cases where, depending on my clinical suspicion, even talking to radiology and figuring out what is the best imaging modality to address that particular question, because we do have a lot of options.
And
yeah, as a medical student, I feel so confused sometimes.
May I, can I just jump in really quick? One more thing, which is just a comment, stepping back, even though the vital signs are stable in this patient, the patient sounds pretty sick in terms of the liver function and the kidney function. And I just want to mention, because I didn't before, that there would be some acute management steps happening at the same time as the diagnostics are proceeding. So the things I'm most worried about right now are kidney failure from what sounds like muscle breakdown. So fluids are going to be an important management step here to at least mitigate that damage as much as possible. And then the liver, there's not too much to do until you find a lesion that you could say stent if there is an obstructive lesion there. But I'm just always thinking about, is this person in acute liver failure? So I'd want to make sure there's no encephalopathy, and would be curious what the INR is to see what state we're in. And with this level of severity, I'd be consulting specialists in liver as well. And there is utility for NAC in some causes of non-acetaminophen liver failure. So I'd be curious if hepatology recommends any acute management steps for the liver at this point. But I just have those things in my head because the organ function is pretty severe.
And NAC being N-acetylcysteine.
So was actually able to get an MRCP very quickly. That was actually back by the next morning. That was chosen instead of CT just because of the severity of the kidney injury and everything. Just wanted to go straight to that to avoid giving more contrast. And the MRCP showed moderate intrahepatic biliary dilation with non-visualization of the gallbladder or extrahepatic ducts. There was a subtle, minimally enhancing mass at the porta hepatitis concerning for a tumor. There was also a small lymph node there that was likely reactive, although metastasis cannot be excluded. Notably, on review, there was no hydronephrosis of the kidneys. Do you want to talk here or some more information?
Whatever you think, Rafa.
Okay.
Oh no, please go ahead.
All right. Yeah, I think the exact appropriate imaging was done here to look at the biliary tract to try to find an obstructive lesion that could explain what's going on. And it does sound like there's a concern for a tumor at the porta hepatis, which is in the hilum of the liver. It's not entirely clear whether that's in one of the bile ducts or just nearby in the hilum, but a tumor that can appear in that location would be a hilar cholangiocarcinoma, a tumor in the bile duct right at the hilum of the liver. And that can absolutely obstruct the biliary tract and cause a picture like this and cause someone to get very sick. So that's a possibility. If it's not in the bile duct, there are metastases that can go to the liver and even to the hilum. Pancreatic cancer can metastasize into the liver and to the hilum, cause obstruction, though most often obstruction of pancreatic cancer is at the level of the pancreatic head. So this tumor sounds more concerning for cholangiocarcinoma. And then hepatocellular carcinoma can appear in any part of the liver, though it's not a intraductal lesion. So curious, next step should probably be an ERCP to look directly and biopsy this lesion and potentially even stent open the bile duct to try to mitigate the damage to the liver.
So biliary was consulted for an ERCP, kind of in the meantime got a PBL that showed a left acute popliteal DVT as well. And so there was kind of some management issues between starting a heparin drip for that, but also holding it for procedure. Thankfully, there was no concern for a PE and no signs of right heart strain. And then kind of in the meantime was started on IV fluids. Had a discussion with the biliary team about like if we should start empiric antibiotics or not. Because the patient was stable, we decided not to at this point, but did get an ERCP with EUS with imaging showing multiple severe biliary strictures in the hepatic system that appeared malignant. A mass was found at the bifurcation of the hepatic duct with biopsy taken, and a right-sided stent was placed. Left-sided stent was not placed due to difficulty passing the stent. And also some concerns about limiting possible further surgical options should this be able to be resected. Because there was the unrelieved obstruction after the ERCP was started on piperacillin tazobactam at that time. Unfortunately, after the procedure, the creatinine continued to trend up despite IV fluids. There was some concern about a little hypotension during the procedure. And nephrology was consulted due to oliguric renal failure. At that time, the albumin continued to trend down. It was now 1.5 as well. Unfortunately, due to rising creatinine, we could not obtain a contrasted CT scan because surgical oncology was consulted as well for consideration if this would be something that could be surgically resected. So we tried to get a PET scan, but because of how the liver often lights up on a PET scan, it showed diffuse body wall edema. It did not show metastasis anywhere, but there was not good visualization of the biliary mass, which was limited. In this time, a CEA level was checked in 1.3, a CA 199 was undetectable. So I'll let y'all discuss kind of further treatment and management here. And one thing I always struggle with is when to get the surgical oncology team involved.
And just to clarify, the CA 199 was undetectably high, is my guess?
Low.
Oh,
it was
really?
actually low. It was not detected.
Okay, yeah, interesting. In cholangiocarcinoma, it's often elevated, and when the bilirubin's so high and there's obstruction of any cause in the biliary tract, CA 199 is often elevated even in the absence of malignancy. So the question was, the primary question about when to get surgery and surgical oncology involved in these cases. I don't know, Laura, if you want to comment on that.
Yeah, so the answer in brief is it very much depends, but generally we're getting surgery involved if once the tumor is more widely metastatic. Usually resecting the primary lesion is not going to help as much unless for some reason they really can't stent it open and we think that we really need surgical control for some reason, but almost always we would just try to stent it open. Usually we're getting surg-onc involved if there's a chance for a resectable lesion that then would improve their outcome in that respect. I think if you're not sure, it's always perfectly fine to ask them and ask medical oncology because in different tumor types, it's slightly different. And so I wouldn't necessarily expect you to remember for every given case. But the general principle is if it's resectable, if we think we can get most of the tumor out, that's when we would try, and we wouldn't try necessarily if it's more widespread. Yeah, and this is a particularly interesting case, I think, because
the liver dysfunction is really severe and the kidney function is getting worse. We still don't totally know why the kidney function continues to worsen. We haven't explained yet the muscle breakdown that we've seen, although there are paraneoplastic myositis cases associated with liver cancer. But I always get worried when there's liver obstruction that can't be totally dealt with. In cases where there's cholangio or other cause of liver obstruction, everything can be stented and you're all good. A case like this, if there's no metastases and there's potential resectability of this tumor, could happen as an outpatient. But in a case like this where the liver function is still iffy, unless it's improving quickly, I think it's a really important inpatient surgical oncology consult, because resection of this may be the only way to reverse the organ dysfunction that's happening.
So throughout the hospitalization, nephrology was consulted with the urine showing some granular cast. There was some concern with the decreasing albumin, even though it was primarily the protein in the urine was primarily non-albumin protein lost, because the urine albumin ratio was like 200 and the urine protein to creatinine ratio was like 3.7 grams. There was some concern that it could be like a paraneoplastic manifestation with like a possible amyloidosis. The serum kappa and lambda free light chains were checked and actually normal. And then SPEP with immunofixation didn't show any other abnormalities aside from low protein levels. Unfortunately, developed worsening creatinine, which necessitated dialysis. And because of some considerations with the acute DVT and kind of other stability, was not able to get a renal biopsy. There was some discussion about if this could be like a necrotizing myopathy or some other manifestation with the elevated CK, but it actually continued to trend down during the hospitalization with fluids. And so like some of that test was originally sent, but it was icteric, and so it was rejected, and ANA was negative. Contacted rheumatology just to kind of have them weigh in. That originally was like you could get an EMG and would not get an MRI of the thighs at this time because rhabdo can be difficult to differentiate. But because it kept trending down, they said, we don't think we need to do this. It was presumed to be all statin induced later, because it did normalize with time. Unfortunately, kind of due to worsening renal function and kind of worsening overall, patient elected ultimately to pursue a comfort-based approach. There was a lot of just like roadblocks during the hospitalization, and we just couldn't get stable enough for surgery and things like that, which was unfortunate. The final, well, I'll let y'all kind of comment here, and then I'll comment on the final pathology.
Wow, what a sad case. You know, any one who gets really sick and ultimately dies from cancer is super sad. I struggle particularly with cases where the cancer is not metastatic and yet causing a severe enough problem with organ dysfunction that it can't be reversed. So that's really tough. I think you made some really important clinical points that I just wanted to highlight. One about the statin as the cause for the liver and the muscle, or at least the muscle piece. Something that I wasn't thinking about that I always need to remind myself of is that if someone's on medications and then has organ dysfunction, that may wildly affect the metabolism of that drug and can increase those levels and worsen the side effects. And statins are known to cause myopathy. I don't have it in front of me. I have to look up how statins, and statically this one, are metabolized, if it's liver or kidney or a combination, but both organ systems were suffering in this case. And so I'm not surprised that the statin myopathy picture got rapidly worse. The other clinical point I'll make, because I see this so often, is acute hypoalbuminemia. Some of this hypoalbuminemia is probably not acute, but it sounds like at least some of it is. And I'll just point out that albumin is a negative acute phase reactant, so the level will decrease acutely in the setting of inflammation of any kind. There clearly was a lot of inflammation in this case with the elevated AST, some ALT elevation, probably some inflammation involving the muscle, maybe secondary to the statin. So I'm not super surprised the albumin dropped acutely in this case. I think there's several reasons why that could have happened and not necessarily protein loss in the urine. I'll be curious to see what the path for the tumor shows. Still suspicious for a cholangiocarcinoma as the likely anatomic cause, but there are other tumors that can manifest in this location, and path is really important in a case like this.
Yeah, I just want to point it out that I also had a discussion with an attendant, and I think statins are only metabolized by the liver, because you can use statins in end-stage renal disease, even though there are studies that show no improved mortality with those drugs. Any other input, Laura?
No, I mean, I think that was an excellent summary. Just thinking about cholangiocarcinoma, if that were to be the diagnosis, it's pretty rare in the United States. It's often associated with primary sclerosing cholangitis, but it's more common in other areas of the world due to liver flukes or viral hepatitis. And so just, if that ends up being the diagnosis, just thinking about what her risk factors might have been depending on where she lived and other factors.
So the final pathology showed clusters of atypical cells and fibrostroma suspicious for adenocarcinoma with signet ring cell features. So this was a really sad case, but also a good learning, an opportunity for the future. One important point about the statins is I think atorvastatin is actually, or some of the statins are through like the CRIP3/4A system. And so this was not the case in this case, but sometimes if you're on H. pylori treatment with certain other antibiotics metabolized through that system, you can actually get rhabdo through that. But here was presumed to be worsening renal and liver function that precipitated it.
I'm excited to jump in to talk about the path findings, and excited is the wrong word because it was a super sad case, but very interesting learning. So signet ring on pathology for cancer is always a bad sign of aggressive disease and is typically found in a subset of GI cancers. Signet ring cholangiocarcinoma is very rare. More common would be signet ring colon cancer or signet ring gastric cancer. And this case is jumping out at me as pretty interesting for a couple of reasons. I think it could still be a very rare case of signet ring cholangiocarcinoma based on the anatomic location, but just pulling it together, H. pylori does increase the risk of gastric cancer, and gastric cancer is notorious for infiltrating the liver very aggressively, especially the signet ring form. However, EGD didn't show a gastric cancer tumor, but there can be subtle cases of gastric cancer that are not endoscopically evident. So I do think that's a possibility here, is signet ring gastric cancer that infiltrated the liver and caused rapid liver dysfunction in a way that may not be radiologically obvious. And cholangio is still on the differential for sure, as is metastatic colorectal cancer with signet ring histology, though again, that should be seen on a colonoscopy, but could have been missed. So really interesting and sad case of a very aggressive tumor, it sounds like.
I think just to compliment you and your team on the care of this patient, I think it sounds like you got all those appropriate studies really fast in a very timely manner. You always look in these cases, what could we have done differently, or how could we have, changed the outcome here? But unfortunately, it sounds like this was a pretty acute finding in her. And she came in when she was quite ill. And so I think, stepping back, managing the liver failure and the renal failure, just a lot going on at that point. But you and your team, it sounds like, did a really good job with that. And just unfortunate that it did present in a way that she was so ill at the time of presentation. So just to say that, I don't think there was anything that really could have been done differently from what you've presented that would have necessarily changed the outcome here.
was definitely a really sad, sobering case, and hard conversations, but also, you know, meaningful. These are like the patients that you remember and think about their family members as well. I don't know if it was mentioned earlier, but I did kind of alter some details in the case, just to protect the identity of those involved. But that's the final case, and thank you all so much for discussing it.
Oh, thank you so much, Sam, Laura. Such an amazing reflection. And MK, thank you for bringing this case to us. And I hope we can learn from this case and always reflect on what we could have done better for our patients, just like Laura mentioned. I think this is such an important activity that physicians, medical attendants, we have to do daily, how to improve best the lives of our patients. And thank you for everyone who joined us tonight. And maybe we can finish it off with Andrea with the teaching points.
Thank you very much. Well, we started with an old patient, elderly patient with iron deficiency. So we talk about chronic gastritis, and because the patient is female, we talk about maybe an OBGYN cause. Then, because the patient is already old, it's common for them to have fatigue. One thing that we tried to put together at the beginning was LFTs elevated and lower extremity swelling. That gave us an idea of aggressive liver dysfunction. Because the patient had fatigue and weakness, we thought maybe it was due to a paraneoplastic syndrome, something neurologic, or due to age. Something to remember is that colonoscopy and EGD does not scope the whole small bowel. There is always a portion that cannot be scoped. Normally, the GI blood loss is the most common most common cause of anemia. We have this patient that presented, because it's immun, we talk about the different kinds of malignancies that it could be. We talk like hepatocarcinoma, that is more common in cirrhosis. Then we talk about liver metastasis, that tends to be from the GI, like pancreatic cancer, that appears more in the head, most commonly in the head of the pancreas, and cholangiocarcinoma. Cholangiocarcinoma can appear in any part of the liver. And now we know that also the gastric cancer can metastasize to the liver, tends to do it. We also think maybe if there was but the patient had bad GI, because cancer tends to make the patients to have more to have a coagulopathy. And when we look at the acute programs, we have the kidney failure due to muscle breakdown and liver failure. We talk about a biliary tract obstruction. And Rafa make a great question about like, Marie make a great question about when to contact surgical oncology, and it's normally to ask if the tumor can be resected. Not normally when the tumor is already metastatic, but there are sections. And then we remember a common side effect of statins, that they can cause myopathy. Something that is always good to know is that albumin will decrease in inflammation. And signal ring is a pathology characteristic that is common in colon and gastric cancer, and gives you that is more common in aggressive cancers. So thank you very much.
Thank you all very much, and I hope everyone have a very good night. And thank you all for joining. And I can't wait to learn from you all again, Sam and Laura. Have a very good night. See you.
Bye.
Thanks, everybody. Thanks for having us.
It was a pleasure.